Hello, and welcome to the workshop, Chemobrain, Steroid Rage, and Other Ways Transplant Meds Affect Your Brain. My name is Steve Bauer, and I will be your moderator for this workshop. It's my pleasure to introduce today's speaker, Dr. Adrienne Mishkin. Dr. Mishkin is Assistant Professor of Psychiatric Liaison to the Blood and Marrow Transplantation and Cellular Therapies program at NewYork-Presbyterian, Columbia University Irving Medical Center. Her interests include psychiatric care of patients with life-threatening illness, cancer, sickle cell disease, infertility and subfertility, medical post-traumatic stress, clinician mental health, surrogate decision-making, public health, access to care, and equity. Please join me in welcoming Dr. Mishkin.
Hello, my name is Adrienne Mishkin, and I'm a psychiatrist. I work with the Stem Cell Transplant and Cellular Therapies program at Columbia University Medical Center at NewYork-Presbyterian Hospital in New York City. Today I'm going to talk with you about some of the medical treatments that are part of transplantation that may have an impact on your brain, mood, or other psychiatric symptoms. We're going to focus in particular on Chemobrain and steroid rage, but we are going to cover some of the other medications that commonly cause psychiatric side effects as well. The learning objectives of this talk are that participants will know about Chemobrain, what causes it, and how it looks. Also about steroid rage, its causes, treatments, and how to handle it. And a little bit about some of the other common medications in transplant that impact the brain, mood, and cognition. So what is Chemobrain? Patients who take chemotherapy often report feeling that they are not as focused as they used to be. It takes longer to think of what they want to say. They may experience short-term memory problems. In general, the theme tends to be that they feel delayed. So this is important in contrasting with dementia. In dementia, patients often experience severe memory changes, personality changes, and even outright confusion. We do not expect those symptoms to come from chemotherapy. It's usually described that the patient will feel it takes them longer to come to the same conclusion, longer to come up with the same word or phrase or idea, longer to get their thoughts across, but not that they ultimately say something that isn't consistent with their previous personality and way of thinking. And I think that's really important because things that change your brain can feel pretty scary. So it's important to know that we would not expect you to be not yourself. And if you are not yourself, we would expect that this is due to some other acute medical cause and not based on having taken chemotherapy. The symptoms of Chemobrain can start weeks or even months after taking the chemotherapy, but once it happens, they do not continue to get worse over time, and some people actually improve even years into their recovery. So is Chemobrain real? Well, yes, everything you experience is real. But most people ask this question meaning, is it medically something that we can explain? And yes, we can. The medical term is chemotherapy-related cognitive impairment. And there are definitely specific biological explanations for this phenomenon. The neurons themselves are being damaged by chemotherapy. Neurons can be long and spindly, or they can be tight and thick. And so the neurons that happen to be flimsier are more likely to be injured and impaired by chemotherapy, which is why people have certain specific things that work slower and other parts of their brain that seem to be working fine. The hippocampus is the part of the brain where memory is stored, and the cells in the hippocampus tend to be affected by chemotherapy. And then there's just the other cells in the brain that can be inflamed, and that can also contribute to the experience of Chemobrain. So I'm going to show you an image of fMRI, which is a type of MRI when the patient or subject is doing a task and they're looking at how much blood flow is going to different parts of the brain while the patient does a task. So in this image, patients A and B were actually identical twins doing a memory task, and you can see that there's more blood flow in the A brains and less blood flow in the B brains, which is a way of measuring how much activity is going on in the brain, because the more activity there is, the more blood you need. And you can see that in the first two images, the A brain has much more activity than the B brain, but in the other images, there's less of a difference. And that's goes hand in hand with what I mentioned, that certain parts of the brain and brain function are more affected than others. So what causes Chemobrain? It can be any type of chemotherapy. Methotrexate is a commonly known cause and a common medication used for transplant patients. Any chemotherapy that you have injected into your spine might be more likely to contribute. Of course, the purpose of injecting chemotherapy into the spine is to make sure that the chemotherapy reaches the brain and protects the brain from any cancer. So, of course, that chemotherapy is more likely to get to the brain. And not a chemotherapy, but radiation that includes the brain also contributes to cognitive changes, and it's a very common treatment that's given along with chemotherapy, so I've included it here in the Chemobrain section. So what about treating Chemobrain? Can we do anything about this? So there actually is a type of therapy called cognitive retraining therapy. It is specific mental exercises that can help sharpen you. There's also a style of finding ways to rely on which things your brain does best. Everybody can do this to some extent. You don't have to have cognitive impairment to want to do this. I'm a person who has an easier time with languages and words and a harder time with math and numbers, and so I always translate things into a way of thinking about them in words, and so I rely more on the part of my brain that works better, and I rely less on the part of my brain that works worse. And there are more complex ways to do this with the support of a trained clinician. This type of therapy can be done with a psychologist, psychiatrist, physical therapist, and occupational therapists, or as part of an integrated center for cognitive retraining therapy. And studies of what the best methods are ongoing. The medication Namenda, which has also been used for dementia, has been studied for protection. There's some signs that this may work, but it's a little bit too early to really say for sure. And there is one study where it showed to protect brains from the cognitive effects of radiation. And thiamine, which is just a vitamin, is also being studied for protection. But thiamine is a vitamin that very often when people have a deficit of thiamine, it can correlate with problems with the brain, nervous system, and spinal cord. So this is a potential hopeful thing that could be added that has pretty much no downside. Now we're going to talk about steroids, which are the other very common part of transplant treatment, because everybody is getting treatment for immune suppression, and then a lot of patients wind up having treatment for graft-versus-host disease or other similar conditions. So steroids are widely used in the transplant arena. There are a lot of psychiatric side effects of steroids. The most common ones are basically feeling anxious, feeling sort of agitated, irritable, an elevated mood, but in a cranky way. It varies tremendously, but in general, the most common experience patients have is that they feel that their emotions are being amplified in one way or the other. But it could be amplified sadness if you're feeling sad. And then there's some less common symptoms that we really need to be on the lookout for, like actual psychosis, meaning seeing things that are not there, hearing things that are not there, having beliefs that are strange and magical, or not being able to get yourself together to focus on what you're doing. Of the people who have steroids, almost 1 in 3 will have a mild to moderate psychiatric side effect. So it's very common. And only 6% will have a severe psychiatric side effect, but of course we need to know about those and how to handle them. When steroids are stopped or significantly reduced, most people who felt sort of amped up on the steroids feel the opposite when the steroids are finished. They feel low, tired, sleepy. Some people can still have anxiety, mania, confusion, but most people feel depleted, like my little cartoon man there. So when, after taking steroids, are you expecting to have these side effects? This is the tricky part. It could really be any time. So about 40% of patients will have some kind of psychiatric side effect in the first week after taking steroids, but plenty will have their first symptoms later. So almost 2/3 will have those symptoms within 2 weeks, and most within 6 weeks. So it's very common that the first psychiatric side effects do not occur the first few days, and so later when they occur, everyone thinks, how could this be from the steroids? You've been on them for a week already. But the average number of days before psychiatric side effects begin is 11. So it's important not to discount the role of steroids in causing these symptoms, especially if there's no other obvious explanation. The symptoms can last up to 2 months after the last dose of steroids. So this is probably something people starting steroids don't want to even think about, that I could have psychiatric side effects the whole time and then even after they're stopped. But it's so important to know that even if it's been a few weeks since your last dose of prednisone, these symptoms are still very likely to resolve over the next few weeks. So what do? Expect that when you take steroids, you're going to feel at least a little bit emotional, that at minimum, for most people, they feel a little bit anxious, they have a little bit of trouble sleeping, and most of their feelings, whether it's sadness, happiness, excitement, anger, are going to feel like they got taken up a notch. If you're feeling overwhelmed, you can do things just to make your room quieter and more peaceful. You can dim the lights. You can make sure that just one visitor is around, somebody who's able to sit and be quiet with you, or somebody that you feel safe, that if you're going to express a lot of emotion, they're not going to judge you or make you feel bad about it later. And of course, if you start feeling excited or distressed to the point where you really can't take it, where you're feeling that you can't sleep at all, where you're thinking that life is not worth living, if you're starting to think that your close, trusted loved ones are no longer trustworthy or anything sort of strange, you're going to want to let your doctor know right away. So what else should you do? So in that scenario, it is not necessarily feasible for your doctor to completely stop your steroids, because if you're taking them for graft-versus-host disease, there may be no good other choice. However, the schedule of steroids sometimes can be changed so that you take them first thing in the morning and then mid-afternoon, and it can help with not messing up your sleep as much as it would if you took it in the evening. And sometimes you can take other medications to counteract the effect of the steroids. Zyprexa is one example of such a medication, and that's often used also for nausea and appetite in patients who are going through transplant and other types of cancer treatments. So there are options for ways to counteract the steroids effect. Sometimes it may require that you be in the hospital to be fully safe. And you may be able to have the oncologist or a psychiatrist come visit you to advise you about how to reduce the risk, keeping your environment calm, and treating any other symptoms like anxiety, insomnia, distress that you're experiencing. What are the other common medications used in transplant that can affect your brain function? Well, there's lots of medications in transplant, so I'm going to go through category by category, reviewing some of what has been seen and which ones are most common. On all of these slides, I have embolded the most frequently occurring psychiatric side effects, and that way you can quickly take a look at the slides and know which ones are most often occurring. So antibiotics, antivirals, and antifungals are very common even as prophylaxis for transplantation, and several of them have a lot of psychiatric side effects. Voriconazole is, I would say, far and away the most common cause of very concerning psychiatric side effects. Patients do experience auditory and visual hallucinations on voriconazole. Usually patients do know they are hallucinating. They will actually report, I'm seeing things that aren't there. But it can be quite distressing. And posaconazole, which is often what we switch to, can somewhat cause confusion and psychiatric side effects, although much less commonly and less intensely than voriconazole. Cipro, another common antibiotic, can cause mental excitation. That's not like enthusiasm. It's like feeling like too amped up, kind of like what we talked about with the steroids. Poor sleep, feeling dizzy. Cefepime can cause delirium. And clarithromycin, Bactrim, and Valtrex also have some risk of causing delirium. Every time I write delirium here, it basically means confusion, being out of it. Some people might feel like they're out of it at certain parts of day, and other parts of the day they're feeling themselves. But this is an extremely common syndrome within patients getting cancer treatments. And that makes sense when you see how many of the medications can partially contribute. Okay, so now medications for symptoms. Nausea medications, although they may have positive effects depending on whether you're having anxiety or insomnia, can often cause more sedation than intended. So Ativan, Zyprexa, Remeron, Combazine, all of these medications can cause sedation. In some cases, you may like a little bit of sedation, and there's nothing wrong with feeling a little bit more relaxed and being able to take a nap, but it's also important to realize that they can impair your thinking. Opiate pain medication, of course, also causes sedation and sometimes confusion, typically more confusion than the medications that I've listed here for nausea. Keppra, which is for seizure prophylaxis, can cause almost any different type of psychiatric symptom because it can change patients' personalities. And anytime I see someone on Keppra and they're acting in a way that the family says is not their normal personality, I suggest that the team consider changing to Depakote or Dilantin, which are also for seizure prophylaxis. So here are some chemotherapies that contribute to changes in brain function. Cellcept being the most common. As you can see, Campath, Cellcept, and busulfan all can cause insomnia and mood changes with busulfan. And then the rest of these agents can cause delirium. Again, that's medically induced confusion, which can be anywhere from just not knowing the correct date to not being able to recognize where you are, why you're in the hospital, being truly distressed. So how much of a concern this is depends on how confused and how distressed you get with your delirium, of course. So I've given you all this medication information about medications that you may have no choice but to take, and telling you that they can have psychiatric side effects that you obviously don't want to have. So what can you actually do with this information that's useful? I believe that knowing what to expect really can help people stay calm even when the symptoms are taking place in your brain. When you go into steroid treatment knowing that when I'm taking steroids I may feel more emotional, that's not information that you'll forget just because you're having a psychiatric side effect. It doesn't mean you won't remember, oh, that doctor I saw on the talk for the survivorship symposium said that this happens all the time. For a lot of people, just knowing that it's common, knowing what the cause is, and knowing that it's probably going to resolve on its own really helps even in that moment of feeling distressed. For the caregiver, of course, knowing what to be looking for that might be related to the chemotherapy treatment, that might be related to even the antibiotics, is really important so that you can be apprising the team if you see any of these symptoms coming up. You could potentially consider asking for Namenda or thiamine for potential protection. These are not well-proven treatments for chemotherapy-related cognitive impairment, but they are very low risk. And you should make sure that your oncologist is aware if you have any previous psychiatric history or family history or other risk factors, so that the oncologist can help with being vigilant about any psychiatric symptoms and changes, and they can know when to call a psychiatrist or health psychologist for assistance in your care. And now I will take questions. Thank you so much.
Thank you, Dr. Mishkin, for this excellent presentation. We will now begin the question and answer session. If you have a question for Dr. Mishkin, please use the chat box on the left side of the screen to submit your question. We will answer as many questions as possible. Our first question is, can you speak to the effects of steroid creams used for localized GVHD? I seem to be experiencing some of these symptoms, such as agitation and anger, but only for about 24 hours after using the cream.
Hi, thanks for that question. That's really interesting. You would think that something you put topically would not affect the inside of your body, but actually we do absorb everything we put on our skin. Even sunscreen does get absorbed into your body. So it's not as common to have psychiatric side effects from topical creams with steroids in them as it is from ingested or IV medications. However, it is definitely possible, and there are reports of that happening. I think it's more common with the very strongest types of creams, like the one they sell over the counter. I want to say it's cortisone, like 1 or 2% is sold as an over-the-counter steroid cream. You would not expect to cause psychiatric side effects unless you accidentally ingested it. But with some of the stronger ones, like betamethasone cream, something that you would be taking for GVHD, yes, it's definitely possible for that to be absorbed and therefore to cause internal side effects.
Okay, thank you. The next question is, my daughter is on Keppra and Celofit. What can be used to help with insomnia?
So it's hard for me to make a specific medication recommendation without seeing the entire list of a person's medications and conditions. So this is not direct medical advice, but Keppra and Celofit do not rule out any of the typical medications that are used for insomnia. So I wouldn't change typical recommendations, things like Ambien, Benadryl, Trazodone, Belsomra, all of the medications that are commonly used for sleep could be considered in the same way that they would be if she were not on those particular medications.
All right, thank you. Next question is there any connection between GVHD and dementia?
So this is a great question, and there's two different parts that I'll speak to. One thing is that it is actually possible to have GVHD that directly affects the brain. This is so uncommon that there are not actually data to say, does having had an episode of brain GVHD cause chronic problems for the brain of any kind, that I've found at least. I've only seen 2 patients ever with brain GVHD, and I've only had 1 patient recover. So the long-term data, I think, are yet to be determined. However, GVHD in general is treated with steroids, and steroids contribute a small amount, but do contribute to chronic cognitive changes. So approximately 7% of patients who have cognitive changes from their steroids, those changes will be permanent. So the vast majority of people recover from any fog related to steroids, but some people do have chronic damage to the brain that results in dementia. But this is a very small percentage, and it's something that if you're not actually experiencing any symptoms of that, it's not something I would say in the long run you should be worried that will happen later. Only if you have GVHD and you're taking steroids for GVHD and you're already having some cognitive symptoms associated with those steroids, those are the patients that I would say should be concerned about that and seek additional medical advice about that topic.
All right, thank you very much. Our next question is, I'm 4 months post-transplant and I definitely have Chemobrain. Will this be lifelong or will it go away? My transplant was for AML.
So at 4 months post-transplant, you're probably still having a combination of factors affecting your focus. So you may be having exactly the syndrome of Chemobrain, but that doesn't mean the only factor is the chemotherapy itself. You're probably still on some kind of immune suppression or steroid. You're probably on some prophylactic antibiotics, and so possibly prophylactic antivirals. So some of those slides that I was showing list each item separately. And I think there are other people who have questions, right? Does this particular treatment contribute to confusion or dementia? But in reality, people are not taking just one of these medications almost ever. Most people are taking these medications in combination. So the part that is from the chemotherapy, strictly speaking, is probably mostly irreversible, may improve a little bit over time. But the aspects that are from steroids, 93% of the time, reverse later on when you're off steroids. The aspects that are related to antibiotics or antivirals or antifungals will mostly improve. The aspects that are just related to fatigue and having been sick for a long time will improve. So for most patients who are several months out of transplant and experiencing these symptoms, technically the part from the chemotherapy may not get that much better. But a year from now, would I expect you overall to feel less burdened by those symptoms? Yes, I would, because it's not really all one thing.
Thank you. Do you recommend any types of activities to stimulate repair of the damaged neurons?
No, I don't think that you can actually repair the specific damaged neurons. We know that people can beef up some parts of the brain. Whether you could work on those specific parts, I think people like the idea that they're fixing the parts that's broken, but in reality, the healthy parts of your brain are probably easier to strengthen. So just like my example with like language versus math, or if I hurt one of my ankles, I might wish that ankle were better, but actually working out the healthy ankle is likely to make it strong enough that I can actually walk because I'm leaning on the healthy side. So I think any of these exercises with cognitive retraining, or where you're just doing all the things people should do as they age, doing crossword puzzles and reading and just using the rest of your brain, can strengthen the other parts so that you're more able to function, even though there may be one part that still does not work exactly how it worked before. And again, we're talking about parts working slower than normal, not that they can't work at all.
Okay. Next question is, I've had mania from prednisone in the past. Does that mean it will happen again if I need to restart prednisone?
So not necessarily. Anyone can have mania from prednisone, and it might depend on whether something like that's ever happened to you before in any other context. But my recommendation for a patient who specifically has had that happen before would be that if they need to start steroids again, that be given together with a small dose of Zyprexa. When people Google Zyprexa, they're going to say that psychiatrist told me I need an antipsychotic, and technically that is what it originally was for, but it's quite effective for mania. And people with psychosis, for example, schizophrenia, might take 30 or 40 milligrams in total a day. And patients with cancer, we usually give something more like 5 milligrams at night. And it helps people sleep, it helps with nausea and appetite, and it helps you to protect you against something like mania or confusion. So the most safe plan would be that if you need steroids again, that you take them together with something that balances things out so that you don't wind up manic again.
Thank you. Next question. Has meditation been studied as a useful tool to improve cognition post-transplant?
Not that I'm aware of.
Okay. After transplant in June 2022, I started on a maintenance treatment with Revlimid in September and then getting Chemobrain in February of 2023. Is it common for Chemobrain to take that long to kick in?
Yes, actually, so strangely, people do often have these side effects start later on. And I don't have a great explanation for why that would be. Some of it might be that early on the patient is just sick, and so everyone assumes it's due to their illness. But we do know there's some evidence for radiation specifically that even patients who are really evaluated quite specifically for what's happening cognitively sometimes do have symptoms that start 6 months or even longer after the radiation. This may be more hard science than my practice. I'm a clinician. I see patients all day. But this is very common, even though it seems totally counterintuitive.
Are brain games beneficial in improving Chemobrain and memory loss?
So, yeah, brain games can be, but again, what you're targeting really is making sure that no other part of your brain goes unused. The idea of doing brain games, luminosity, crossword puzzles, any of these things, is to make sure that you are using all the parts of your brain, because the sort of expression like use it or lose it, it actually is true with the brain. You want to exercise all the parts of the brain that you can, and people who just sort of stare at the ceiling or watch a lot of TV, and sometimes when you've been sick, people might even encourage you to do less stuff that might feel right when you're recovering. But it is good to use all of your brain. But are you necessarily really recovering the part that got affected by cancer, or are you just strengthening everything else so that your total functioning is better? I think it is more likely to be the latter.
All right, thank you. Are there any apps, programs, etc., that a stem cell bone marrow transplant can use that helps with the Chemobrain caused by the heavy-duty chemo used with transplant patients?
Right, so again, the kind of program that I would recommend is called cognitive retraining. And I think it is something you have to do with a professional. I'm not aware of an online do-it-yourself cognitive retraining program, because some of it really has to do with assessing what parts of your brain are working best and what's easiest for you and what parts are harder. And without somebody else looking from the outside of your brain, it would be very difficult to do that on your own. But it's not only super specialists or subspecialists like me who can do this. A psychologist can do this, and there are physical therapy, occupational therapy offices that also offer some cognitive retraining. So there are lots of options of ways to get this type of treatment.
Thank you. Does COVID add to the Chemobrain effects, or does it present differently, even if someone has not been given dexamethasone for COVID-19 treatment? So
I'm not sure if your question is about COVID versus Chemobrain or if it's about COVID and Chemobrain, so I'll answer both. I'll answer the latter first because it's simpler. There are not yet good studies of patients who've had COVID and chemotherapy and any additive effects. But there are lots of reports comparing COVID's cognitive effects to Chemobrain, and the reports are very similar. Actually, the reports of most of the cognitive symptoms of chronic inflammatory illnesses, such as people who have cognitive symptoms in chronic fatigue or some of these newer syndromes, even mom brain, a lot of these symptoms, what people are talking about, are really similar. It's the sense that you cannot quite think of the word you want as quickly as you normally would, or that maybe it even takes a few minutes to think of that word. It could be that you go into a room and then you can't think of exactly what you were planning to do, and it takes you a few minutes to remember, but that it doesn't necessarily get worse over time like dementia would. In true dementia, you would have symptoms like that, and a year later, you might be confused at a much larger scale. With these syndromes, the symptoms don't really change very much, and they don't progress to personality changes or not recognizing people or anything like that. So we think that these are probably similar syndromes because they're the effect of general inflammation in the brain, but there are not data to say if you get COVID and then have chemotherapy or vice versa, what's the expected additive presentation.
Okay. Our next question is from a long-term survivor. How does total body irradiation along with chemo and prednisone affect the brain? I am 28 years post-transplant. Have been off all meds related to BMT for 27 years.
Wow, that's a long time. That's great. I'm not sure if that information at the end was part of the question or just letting us know. Certainly after 27 years, whatever side effects you had back then would be what they are. I wouldn't expect them to change now. Irradiation is probably the single worst effects on the brain of those things that you mentioned. People who have irradiation that includes the brain usually do have some kind of permanent cognitive deficits. And they're not always only in the category that I mentioned in terms of chemotherapy. If you're asking what about like combining those three things, I think actually in this world of post-bone marrow and stem cell transplantation, pretty much everyone who got brain irradiation also got chemotherapy and at some type of immune suppression, if not exactly steroids, something related to steroids. So I think all of our data are really referring to patients who have had all three. And I would say typically after brain irradiation, you do see some cognitive changes for a lot of patients, more than half, I think.
Our next question is thanking you for the presentation and asking, are there any books that you can recommend for emotional health when facing chronic illness?
That is a big question. Honestly, I hope that this is not a cop-out, but I don't think that there is any book that I would recommend universally. When I recommend a book to a patient, it's usually because I really think that the author of that particular story or memoir or document would connect with that particular patient and their perspective. And I don't think that there are good one-size-fits-all narratives that equally apply to everyone. And actually, one of the things I always worry about, because I treat almost exclusively bone marrow transplant, cellular therapy, and stem cell transplant patients, is that if you read a memoir by someone who had a much less lethal type of cancer, that sometimes they can be sort of overly positive in a way that's sort of unfair. A lot of memoirs are written by breast cancer survivors who have been through plenty, but it's not necessarily applicable to someone going through a stem cell transplant. So often the literature that's available is less applicable when you have a very unusual diagnosis or you're going through a very unusual condition. I cannot say that I have located literature that I believe applies to all of the patients in general.
Thank you. Are there any psilocybin treatments for anxiety, depression, etc. after a bone marrow transplant?
So psilocybin is really still being researched for use for psychiatric symptoms. And I'm sure lots of people listening to this presentation were part of research when they were getting their cancer treatments. But when it comes to treatments that are under research for things other than cancer, a lot of the time, cancer patients are actually excluded from the research population because you're looking at something, because researchers are trying to look at the treatment in an isolated way. So psilocybin is a good example of something where at this point in time, they would still only be testing on patients who have essentially no other medical comorbidities. And they would also probably be testing only on people who are severe sufferers of depression. And most people who have had a major medical problem and go on to have depression, even if they might be just as depressed, it would be considered sort of a different syndrome of depression related to adjustment to illness or something like that. So I think that research for patients with cancer will come only if depression and anxiety are successfully treated in an isolated way with psilocybin, and that, to be realistic, patients who have had bone marrow transplants specifically would probably not be studied even longer, or at least not recruited. They might not be excluded from the research, but they probably wouldn't be specifically studied until there were evidence created specifically for cancer and depression. So unfortunately, once you've been down a path of having this unique treatment, it means that the data that you might want to have for patients just like yourself may take even longer to be created, because first they have to prove that it works, then they have to prove it works in cancer, then they have to prove it works in cancer after a particular treatment.
Okay. We have several questions that are kind of related here, so I'm kind of lump them together.
Sure.
Does Chemobrain eventually clear in most patients? And how long can Chemobrain last after the treatment has ended?
Yeah, so it does depend on your age and your neurological functioning prior to getting chemotherapy. The range is wide. I would say for most people, for the vast majority of people, they feel it is not fully reversed later. But depending on age, younger patients are sometimes able to recover more of their cognitive functioning. And there was one poster I saw a few years ago that showed a series of patients who got transplanted around their maybe early 20s that did actually recover cognitive functioning, at least on testing. I think the answer is sort of somewhere in between, that you might not have the exact cognitive functioning you would have had if you'd never had the chemotherapy, but more than half of patients do not have the full cognitive functioning they would have had without chemotherapy. But more than half the patients with cognitive changes are still very much able to function, sometimes by using these compensatory strategies like what I described before, of like, well, I know that I tend to forget things, so I just write them down. Or I know that I can't always think of the word off the top of my head, but I know I can just describe my way around what I want to say. And so it doesn't necessarily affect them in their lives as much as it initially seems like it's going to.
Thank you. Is my occasional aphasia seen in patients who have had chemo to the brain?
Yes, absolutely. Trouble finding words is the single most common complaint.
Okay. This is a little longer question, but here it goes. I am an AML patient and had a BMT 7 months ago. For the first 6 months, I was mostly focused on just getting through the day with constant nausea, digestive issues, and other physical challenges. Once I began to feel physically better, I started to suffer anxiety about the remaining relapse, risk, and flashbacks of the struggles I experienced while being hospitalized, something like PTSD. Is that common, and what can I do to help myself?
So yes, that's extremely common. So I'll tell you a little bit more about my role. I evaluate patients universally coming in for allogeneic transplantation at my center, and anyone else who wants to. And I'm available to patients who have gotten any type of transplant as video visits after their transplant has happened, and I also see patients in the hospital. There's a good number of patients who, after they met me once for their pre-transplant clearance, never want to see me again, not personally, but just don't feel that they need anything. And I hear from them 6 months or 12 months, or sometimes even 24 months after transplant. And I think it's exactly what you're describing in your question, that when you start to feel physically better, sometimes is the moment that you suddenly start to mentally let in everything that's happened to you. Or that maybe in your mind, you thought, okay, I can handle this for 6 months, or I can handle this for a year. And when you don't feel 100% back to normal at that time point, the significance is very different. So yes, 100% starting to get anxious about what's happened to you 6 months later is very normal. And you can't even really say whether it's post-traumatic stress yet, because in a way it's still going on. This may be the moment that you finally feel well enough to really absorb everything that's happened and start to process it. So you may have the symptoms of PTSD, but technically PTSD is post, so that's why I phrased it that way. I think that this is really the time to speak with a mental health professional, right? Obviously, I'm a psychiatrist, but listening to me for an hour or whatever this is no replacement for getting your own treatment. And I know that seeing a psychiatrist has all kinds of different meanings to different people, and also depending on where you're located geographically and what kind of insurance you have, it may just be feasible or not. But there are lots of other types of professionals who can serve the role of helping you process what's happened. There are a lot of social workers who have private practices where they do therapy. There are nurse practitioners in psychiatry. There are psychologists. And sometimes if you're in a location geographically where none of those things are available, there's probably some experience on your primary team of talking with patients about their experience as well. And if you're feeling like you might have post-traumatic stress, or you might be headed towards post-traumatic stress, then I think it's extremely important not to be alone with that, and not to assume that your family can necessarily help figure out what to do, but really to reach out to your medical providers and ask for their input. There are, of course, some doctors who are not psychiatrists who just go straight to, like, here, have an Ativan, and that's not usually what I would recommend. But just talking about with your oncologist, especially, like, what is the risk for relapse, and when do people start to feel like this is over? And for many people, I don't think that question said the diagnosis. I could be wrong. Maybe it did. For most diagnoses, around 2 years is when the doctor starts to feel more relaxed that you're not really going to relapse. And so even if your oncologist is not the kind of person to be giving therapy, you can still have a discussion with your oncologist or their staff about when would they start to feel more relaxed, and when do patients usually stop worrying, and what can be done to help you manage those feelings. Maybe you could have your labs done more often or less often, depending on which makes you more anxious. Some patients want their labs done more often so they can feel reassured they're not relapsing, or other things like that. And if it's possible to get into therapy to really talk about all those feelings, I think it's very valuable. I spend 50% of my time just with one bone marrow transplant program supporting those patients. And I know not every program has that, but every program should have someone they can refer you to in the area, because it's really important to talk about what you've been through, and not only with your family, but with a professional who can listen objectively and advise you.
Thank you. Next question is, do you have any statistics or flowcharts on how to discern between CAR-T neurological side effects versus the TOSI and steroid toxicity side effects you covered in your slides?
So the side effects of the CAR-T are really completely different, but definitely it's very different. The time course, first of all, is extremely different. So in the first week after a CAR-T, the cytokine release syndrome it's not something that could happen. It's what happens. People have headaches, nausea, trouble breathing, body pain, and just feeling crappy. So that's the expected side effect that starts about a week after CAR T. Then there's something called ICANS, which happens in the first month after CAR T. This is going to happen in up to 62 to 67% of patients, depending on their primary diagnosis, with leukemia patients being affected slightly more often than lymphoma patients. This causes an expressive aphasia. That means when people talk to you, you know what they said, and when you talk, you can't get your words out. Tremor, dysgraphia, which is where your handwriting gets tiny and weird, and lethargy, which doesn't just mean feeling like sitting on the couch. It could mean like you can't even be woken up fully. It can progress to global aphasia, meaning you can't speak at all, seizures, being obtunded, which means we can't wake you at all, or like even like a coma, which is very rare, but in comparison, it can happen. And the treatment for those is steroids. And for patients who have ICANS and are treated with steroids right away, they pretty much wake up almost right away, like within 1 to 2 days. So this is a very different syndrome that's more on the neurological end, in that people actually can be unconscious, can be unable to speak, can have seizures. But we work with neuroimmunology most of the time for patients who are having post-CAR T side effects.
All right, thank you very much. Next question is, after long-term dosage of prednisone, I was prescribed Zoloft. I am no longer on prednisone, but I haven't stopped the Zoloft. How might this be affecting me?
Well, it depends on the dose of Zoloft and whether you need it. In terms of side effects from Zoloft, which I think is what you're asking, the main side effect of long-term side effect of SSRIs is decreased libido, meaning decreased interest in sex and a longer time between starting a sexual act and being able to have an orgasm. About 1 in 3 people, regardless of sex and gender, will have sexual side effects related to an SSRI. Other than that, the side effects are pretty idiosyncratic. There are people who poop a lot more often when they take Zoloft than when they don't. There are some people who poop less. People get hot. Some people get sweaty, but not necessarily hot. But most of the side effects are pretty subtle and pretty much individual. And for the average patient who's been on Zoloft for more than 6 months, the only side effect you would expect would be decreased libido. So whether you actually need Zoloft or not is, I think, a different question that I can't really answer based on the information you've given.
I'm sorry, he did also state 50 milligrams of Zoloft, if that has any effect.
50 milligrams of Zoloft is a low to medium dose. So a full dose of Zoloft is 200 milligrams and a baby dose would be 25. If you did want to get off of Zoloft, I cannot tell you whether that's safe for you or not based on not knowing your psychiatric history, but I can tell you that there is no withdrawal from Zoloft. So even if you just stopped it, most likely you would have no withdrawal at all because it self-tapers over the course of several weeks. But if you wanted to decrease to 25 milligrams, there would be nothing biologically dangerous about doing that on your own. But of course, I don't know whether you've had any psychiatric risks, such as having suicidal thoughts or anxiety that would prevent you from being able to take care of yourself or anything like that. So I cannot advise you about whether this is a good idea, only that from a biological perspective, that's not a medication that needs a lot of tapering. I think that we're nearing the end of our time, Steve.
Yes, I believe this is it. And that would have to be our last question for today, unfortunately. On behalf of BMT InfoNet and our partners, I'd like to thank you, Dr. Mishkin, for a very helpful presentation. And thank you, the audience, for your excellent questions. Please contact BMT InfoNet if we can help you in any way. Enjoy the rest of your day and the rest of the symposium.